Thanks again, sir, for giving me this opportunity. And definitely, the talk by Dr. Rakesh made my job easier because the data in the first line has been discussed in detail. So now I'll be discussing about the data maintenance strategies in the recurrent ovarian session. So moving ahead, next slide. So definitely it is an unmet need because recurrent ovarian cancer, when once it recurs, there is a high chances of recurring it again and again, and that also at very smaller PFS. Initially the PFS is broad, for example, average 15 to 20 months. Later on it becomes shorter and shorter, as low as 2 to 3 months. That is why we need some strategies by which we can increase the time of progression-free survival and repeated chemotherapy, because the patients tend to get frustrated by repeated chemotherapies, and they also tend to abandon the treatment significantly. So we'll discuss about the same. Next slide. So coming to the first point, yes, epidemiology, I'm not going to detail of it. We all are very aware of it. Next slide. So it is in the worldwide, it is 8th most common. In India, it is 3rd most common. And if you ask me, when we didn't have any BRCA related data, we thought BRCA genetic mutations might be there, but it's not so common. But now when we are sending BRCA genetic data analysis, we are finding significant number of patients, at least 30% of our patients to harboring BRCA1 and 2. So definitely it is an eye-opener in the last 2 to 3 years, and also data coming up from a multi-center data from Sudhir Gupta sir and others. It has clear that yes, a large number of patients of ovarian cancer get a BRCA1 and 2 mutation in our country. So it's an important thing to be noted. Moving further ahead, next slide. So this is what I have just told. 18 months with or without bevacizumab, and later the 70% tend to relapse. So the relapse rate is so high, so that we need to counsel our patients. Out of every 4 patients, 3 patients with relapse. So 5 years survival is 35 to 40% only. Let's go ahead. Yeah. So what happens? You can see this curves where the patient underwent surgery, chemotherapy. After PFS of 1.5 years, develop again symptoms. Again receive second line treatment. Again the PFS is 10 months. Later on, in the 3rd line, PFS becomes shorter to 6, 5, then 4 months. So very clear. And later on, usually the terminal event is due to bowel obstruction, and the patients suffer poor performance status. Next slide. And also what happens, you can clearly see the platinum free interval is initially more than a year usually, but later on it tends to become shorter, and later patients become unfit for platinum. And even patients who are platinum sensitive, a significant proportion of the patient develop carboplatin hypersensitivity. So when we analyzed our data, we found that the patient who were receiving 3rd time carboplatin, at least 30% were carboplatin hypersensitivity. So in such patients, there is an option to utilize cisplatinum versus omitting platinum altogether. But yes, a large number of patients are not fit enough for receiving cisplatin, and that is why we need a good treatment by which the platinum disease-free survival, platinum progression-free survival can be significantly prolonged. So here we need to discuss about the maintenance treatment option. Next slide. This is data about the BRCA. We'll discuss. Next slide. Yes, next. Yeah. So this is patients with BRCA mutations and non-BRCA, germline and tumor. So let's discuss about germline BRCA. Believe me, though HRD coupons are available from AstraZeneca, the problem is that most of the time the tissue becomes an issue, and sometimes we are not able to get HRD scoring. But now HRD scoring is coming up in a big way, and multiple Indian companies are also doing HRD scoring. That is why a number of patients who are undergo HRD testing is significantly increasing. It was practically 0 2 to 3 years back. Now it has increased. Around 10% of our patients now undergo HRD testing. a significant number of patients now undergo germline BRCA testing. In my center, the experience is around 30 to 40% patient can undergo germline BRCA testing. So around 40 to 50% patient undergo BRCA1 testing. Though we want to test many more patients, it is logistically not feasible. Many of the time it is due to cost issue and other problems. Also, the patient refuses for the genetic testing. Before genetic testing, we always give pre-test counseling in our hospital, and we try to give the implications of testing, because this should not happen. The patient comes as BRCA1 and 2 positive, and when the patient realizes this has very significant family implications, the patient is in a state of severe trauma, mental trauma. So that is why pre-counseling and giving them information is essential. Sensitizing the patients is sometimes difficult, takes a significant amount of time, and that is why we need to have a dedicated genetic clinic at all the high volume centers. Next slide. This is the function of the BRCA1 and 2 gene. I will not go into the details, but these are one of the important questions for the students. Why these are most commonly mutated genes? Because these are the biggest size genes. That is why they are prone to develop mutations. That is why BRCA1 and 2 are the most common genes involved in the mutations, especially in hereditary cancers, especially with ovarian and breast cancer. Next slide. So we need to inform, it has definitely a prognostic significance, therapeutic significance, and also family significance. Also, the patients who are diagnosed to have a BRCA1 and 2 mutation, they need to undergo surveillance and screening for breast cancers as well. And even some patients, and they tend to adopt bilateral mastectomy as well as a prophylactic measure. So this has happened at our center as well. This was initially very uncommon, but due to Angelina Jolie effect, this has become somewhat more common. And especially the patients who are able to search on the Google, and they are able to read on the Google, they come and ask about this BRCA1 and 2 in our real practice. Next slide. Yeah. So all the guidelines support BRCA testing in the routine practice, irrespective of the age. We all testing, it should not be limited by the age or patients who have family history. Around 20 to 30% patients who do not have a family history are found to have BRCA1 and 2 mutations as well, where we found that there was a significant number of patients without family history. So family history should not be taken as a selection criteria for testing for BRCA1 and 2. It should be done in all cases. Next slide. And besides this, there is clear data that somatic BRCA mutations is important. For example, if 20% patients are having germline BRCA mutation, additional 10% will have somatic BRCA mutation. So if feasible, test the tissue. That is the best way to go. But I completely agree, this might not be feasible due to various logistic constraints. In practice, most of the patients undergo germline testing, able to do somatic testing, because at least 10% patients will be able to go find mutations. And also, if HRD scoring is feasible, that is the best way, because out of every 2 patients, 1 patient. But when we'll discuss about the recurrent data, I'm sure it has importance and implications, because the quantum of benefit is different for different subgroups. That is what I wanted to highlight. Next slide. Yes, so 15% will have around somatic germline BRCA, or additional 5 to 7% will have somatic BRCA. Next slide. And so overall, 40% patient will have some or other form of the BRCA mutation with no relevant family history. Next slide. Only tumor BRCA testing is able to detect both germline and somatic. The problem is that after doing, if you detect a somatic BRCA, you should do germline testing because it's important to know whether this is being carried in the blood or not, because it has familial implications. So if somatic is positive, please go ahead with germline after pre-test counseling. Somatic testing doesn't require pre-test counseling, and that is why it is very easy and it does not require too much efforts. But it is always preferable to do if somatic comes as positive, do germline testing as well. Next slide. And this is important because tissue handling is very important. And this is about the classification of BRCA1 and 2 variants. VUS, an important update. After every 6 months, the data keeps on updating. For example, patient who was identified to a BRCA1 and 2 VUS later found to have has now reclassified as pathogenic. So it becomes very important to revisit the VUS status. So always keep your lab involved. Do testing from the lab, which is actively involved in patient welfare as well. Always ask the lab to recheck VUS reports every 6 months and inform you and the patient, so that if any reclassification has occurred in the last 6 months, your patient and you should be informed that this is not, in fact, not VUS and it has no pathogenic. So that will change the treatment and it will have significant implications for the family. That has medical legal aspects as well. So please be informed. Next slide. Coming to the olaparib first line. Next slide. Yes, next slide. Yeah. So Parp inhibitor, synthetic lethality, we are very well aware of this concept. I'm moving ahead. It leads to repair of the pathway, but if there is already a repair defect, heterozygous repair defect, and Parp inhibitor is used, it will lead to complete inhibition of the repair, and that is why the tumor, it will have significant implications in the tumor progression, and tumor progression will be inhibited. That is how the Parp inhibitors work in a nutshell. Next slide. This is I already discussed. Apart from BRCA1 and 2, there are various other genes which are involved in the repair process, DNA repair process, which include RAD51A, RAD51D, and these are also important for carrying the BRCA2 to the strand and later on involved in the repair process. And if these are also mutated, if this is all mutated, but BRCA1 and 2 is not mutated, still it contributes to pathway where the Parp inhibitors will work. That is why it is good to do not only BRCA1 and 2, but to do HRD scoring. And that is why sometimes we tend to do a gene panel of around 12 to 13 genes, and which is important. Next slide. And this is SOLO-1 trial. We have heard from it from the time we were doing our super specialty training, and this included all the patients in the first line settings, newly diagnosed patients with germline or somatic BRCA mutations, patient underwent cytoreductive surgery. Next slide. This is the randomized global phase 3 data, were randomized to receive olaparib versus placebo alone after chemotherapy, platinum-based chemotherapy. Next slide. 2 years of treatment were given with primary endpoint of investigated progression-free survival. Next slide. And median age was 53 years, both in the same group. And in our patients also, we find around 40 to 45 years. In India, everything is around 1 decade younger. So we find more and more patients in the 45 year of age group. And that is data. Next slide. Currently, though respond to chemotherapy, but later progress on the same, and after a platinum-free interval of 10 to 18 months, and the patients who are having BRCA mutation, they fare poorly and they tend to recur very fast. So that is an important problem. Next slide. 2/3 patients had got upfront surgery, but later on it can these patients tend to relapse fast. Though the response to platinum-based treatment is very, very good initially, but later on it wanes off very rapidly. And that is why it is important to understand the problem in this situation and utilize the correct maintenance treatment, best possible maintenance treatment in this scenario. Next slide. Next slide. Yeah. So if we see the 5-year progression-free survival, I will directly come on to the point. 5-year PFS of 21% versus 48%. That is very, very huge difference, more than doubling the progression-free survival at 5 years. And you can clearly see the curve separate as early as 3 months. That is the time of first assessment. And the curve continues to remain separated. That clearly tells, yes, the drug is effective. It starts to work very early. And it not only prevents early recurrences, it also is preventing delayed recurrence, and that curve is completely separating, a huge separation in the curve, which can be seen only with Parp inhibitors in a case of ovarian cancer. No other drug, in fact, bevacizumab only can add a few months, 1 or 2 months, but here Parp inhibitors is definitely adding a significantly addition in the progression-free survival, and it is if it is managed well, a physician has adequate experience in managing the toxicities. Most of the time, it can be managed very well, and we have now experience of utilizing 100+ patients on PARP inhibitors and reducing the dose at the correct time. Managing the toxicities is the key. Then the patients can continue on their treatment for a long time. Next slide. This half of the patients had progressed within 12 months, and early progresses can also be prevented by utilizing olaparib. That is very clear from this data. Next slide. And it is very important to understand that a consistent benefit was observed in all the subgroups. You can see the forest plot. When a drug is having a very good hazard ratio below 0.5, it is expected that all the subgroups will benefit, and that is what you are seeing. All the patients are getting benefit, irrespective of the performance status, BRCA status, age, and all the patients are getting benefit. So it was very clear the drug is benefiting all the patients. Next slide. But because the drugs are expensive, we need to find the best scenario where the patients are getting benefit. We try to do testing, especially in the first line setting. Though the data is there, we can utilize it in all the patients, but we need to counsel the patients. If patient is very well affordable, we can utilize it in other subgroups. But at least there has been recently a meta-analysis published again from TMH Mumbai by Professor Sudhir Tasar, which has clearly suggested HRD positive patients or BRCA positive patients are getting significant benefit from the PARP inhibitors in the first line, but HRD negative patients are not getting so much benefit. But if we see about the recurrent ovarian cancer, the situation is different. In fact, all the patients are getting benefit because after recurrence, they tend to develop recurrence much faster, and that is why in recurrent settings it is approved irrespective of BRCA mutation or germline mutation. Next slide. This is the time to next treatment or death. It has changed from 15 months to directly 52 months. So 15 months versus 52 months is a very big difference, and this efficacy was observed beyond anything, and hazard ratio is 0.2. Again, this is one of the scenario like in adjuvant osimertinib in the ADAURA study. This is another study where hazard ratio is in the range of 0.2 in any oncology trial, which we need to keep in mind. Next slide. So this is highlighting about the efficacy of the drug, which is very extraordinary efficacious in selected cases. And as I told, adverse effects are there. It is not without any adverse effect, but it needs to be managed well. And now with more and more experience, all of us have learned how to manage it. Do not give treatment PARP inhibitor for directly 1 to 2 months. Call your patients, and if not possible to call your patient, at least ask the patient to do at least CBC and LFT at 7 to 10 days and mail it to you. Then you will be able to manage the toxicities, and that is why it is very important to closely monitor, especially in the initial 3 to 6 months. After that, the dose is set, and most of the patients tolerate it very well, because you need if you're starting the full dose, you will need to reduce it significantly. Most of the patients tolerate the dose of 300 milligram BD. Sometimes you need to reduce it to 250 milligram BD. That is why it is very it should be titrated accordingly, and it should be under close monitoring, especially in the initial period. Next slide. The things to look for is anemia, thrombocytopenia, and fatigue. These three are the most common. MDS, yes, MDS occurs in around 1% of the patient, but whether it is directly related to PARP inhibitor or it is due to disease, it is not clear. But still, this should be discussed and told to the patient, especially patients who are very cautious. And in the first line, it becomes more important because patients are getting treatment for a very long time. But in the recurrent settings, most of our patients get treatment for somewhat lesser time. But again, if you're using a recurrent setting as well, the treatment goes many times beyond 2 years, and that becomes a problem in terms of cost issue. But otherwise, it gets tolerated well. Next slide. Even after 2 years, we tend to stop if the patient does not have very significant burden, but in selected cases, we can continue with the patient is tolerating well. And this is what I have just discussed. New second primary malignancies that tend to develop in olaparib arm. Even in the placebo arm, you can see 2%, because these patients are having hereditary predisposed to develop other cancer, including breast cancer. This can occur. ILD can occur in a small number of patients, but it is not very common. Next slide. Also, hazard health-related quality of life is somewhat similar, and the patients tend to remain in having good symptom control for a long time. That is why the quality of life is preserved in patients who are receiving olaparib in this setting. Next slide. And that is why in the Paula 1 trial, again, which was treating non-BRCA mutated patients, olaparib plus Bev versus Bev, where olaparib was utilized for 2 years. Now there have been further updates. Now again, a point which I would like to highlight: in real practice, it is somewhat difficult to utilize bevacizumab plus olaparib, because bevacizumab patient will have to come 3 weekly. But in real practice, for olaparib also, the patient needs to come at least once a month to the OPD if feasible. If sometimes if patient has already received treatment for a year, then we can call it around 2 months. But I try to call every patient once. If you want to use olaparib plus Bev combination, it is feasible now. But now, with a discussion from various international experts as well, bevacizumab has completely different mechanism of action. And if patient had very significant effusions, especially when the patient had pleural effusion at the baseline, I tend to utilize the combination of olaparib plus Bev. The toxicities are there, yes. And also bevacizumab utilization in various doses. If you most of us are now comfortable in utilizing not 15 mg per kg but 7.5 mg per kg. So these points we take into our real world practice to make the drug more and more suitable for our patients. Next slide. And this is data again from the Paula 1, where baseline characteristics were matched, being a very good well conducted randomized trial. Next slide. This is the around 500 plus patients randomized in olaparib plus Bevam. Bevam had 2:1 randomization, so it was around 250 patients. Next slide. Disease progression was the most common cause of discontinuation, and again you can see a hazard ratio of 0.59, so close to a hazard ratio of 0.6. This is very, very clear, and this drug combination seems to give a very good benefit. Next slide. And patients, and the PFS difference is again significant. But here again, if you see, the HRD positive patients are tending to get the benefit, 0.33 hazard ratio. HRD negative or known hazard ratio is 0.92. So this helps us to select in our mind which patients are going to benefit, though it can be given to even BRCA negative and HRD negative, but we know HRD positive patients are going to get the maximum benefit, and we counsel accordingly in the real practice, though approvals are to all the patients. Next slide. These are the again, all the patients are seeming to get benefit. Next slide. Yeah, let's move to 3 slides from now. The toxicities I have already discussed, and this tend to remain similar. And to conclude, a 67% reduction in the risk of disease progression was seen with olaparib versus placebo with hazard ratio of 0.33. And yes, this combination is feasible in the real setting. And previously, though I also had resistance to utilizing this combination, I now tend to utilize this combination in patients, especially who are BRCA negative but HRD positive. This is the subgroup I think will have the maximum benefit. But yes, it can be given to all the patients. But the differential benefit should be conveyed to the patient, and decision should be taken by the patient if the patient is affordable for the treatment. Next slide. And this definitely has implications which I have already discussed, and I would like to stop here because the time is exceeding. Thanks. Thank you. Thank you.
Thank you, Dr. Akhil. It was a wonderful talk, and you cleared the many things in audience mind, and your actually the ideas are very clear, and your practice is reflecting in that. So we are coming up to the last session, and this is a actually a panel discussion. So Ekta, okay, I would introduce